Welcome back to another PCBH Corner, and for the second time, we have Kirk Strosahl joining us, and there's a lot of different things that we want to talk about, and I don't even know what the first question is that I want to ask you. One of the things that I think was a good jumping off point, we last night were out on our deck and having a lot of good conversations, and the thing that started everything was just, what are you working on right now? Like, what's the thing, you talked about this new book that you're gonna be having coming out. Would you wanna just tell people, like, what are you working on? What's this new thing that you're approaching?
Yeah, it's a book on acceptance and commitment therapy for crisis. And it kind of takes a different spin on human emotion and kind of the role of human emotion in adaptation, using a theory called predictive coding theory, which is based in neuroscience, but I think it has an immediate clinical application to clinicians working with people who are in crisis.
Let me ask you this, and I didn't ask you this last night. It seems like every single time we talk, and if you're ever at a conference and you get to see either Kirk or Patty go up and pick their brains, where there's always something new that you're looking into to kind of, I don't know if it's to iterate your knowledge or to evolve perspective, but even this latest thing, this predictive coding, what causes you to always be looking at different ways of approaching stuff? Like this most recent iteration of this book, was it just something you stumbled upon? What caused you to, or what causes you to always be thinking outside the box, these new ideas?
I think our understanding of how people change and what to do to be consistently effective is actually way more limited than we're willing to admit. And so I'm not satisfied that I know what I need to know to help the maximum number of people I can in the space that's allotted to me, in a visit. So anything that, if I was studying how to wave crystals in a certain way that would work reliably to improve 10% more people, I would be a huge studier of crystal waving, right? Predictive coding is just one example of things that are sitting outside the field of psychology proper, that actually are inside the field of psychology if you just do the cross-level application. And I think over the years, one thing that I've been especially good at is integration, sort of integrating concepts from both within clinical psychology, psychopathology, and then outside neuroscience, cognitive science, and behavior analysis and things like that allow you to see people, I think, with a much more rich texture. And texture for me basically means the richer the texture, the more angles I have to explore in a visit with somebody that might potentially create radical change for them. I think we're always searching for angles, and if you have one angle when you get to the end of a visit with somebody, that's not a very good feeling. If you have 10 angles and any one of them is potentially a game changer, then you can relax, settle in, you can allow the patient more choice, right? You have a much bigger pantry to pick from. So I don't think that process should never stop for any person who's a clinician.
Let me ask you this, because I think, man, that got me hyped. So many different levels. The thing that I think is inherent within that is having this willingness to not hold on to things, if we want to call it rigidly or harshly, just being open, which sounds good in theory. I mean, that sounds great. That's what people do. Reality, I think, is more difficult for that. It was someone like you and like Patty, who, you've developed these theories, you've developed these models, and to still have that ability of holding on to things gently. That's impressive. Is there anything that you do, and this probably isn't, I might say this probably isn't going to be a good question, but is there anything that you do that helps prompt that continued curiosity, that continued, you mentioned about, wanting to help patients and stuff, and that's great. And like, is there anything else that you do to really just continue to promote that?
Well, some theories are developed from the top down, so they're largely intellectual propositions, and then they get, drizzled on the profession. Other theories, the game-changing theories, I would contend, start from the bottom up. They start from the level of clinical observation and practice. And they filter back up. So two really good examples of that are ACT, which has started as basically the study of human language, right? And cognitive therapy. Aaron Beck was a psychodynamic, psychoanalytic therapist for years, working with depressed people, and noticed that they were systematically declining in therapy. And he noticed at the same time that they had this propensity to think in certain stylistic ways. And out of that, he developed a whole theory, which was largely practice-based, right? So, some people think that the job of theory building, model building should be left to the academy. And I think it's more of a partnership, and probably 60 or 70% of the real game-changing models are going to come from the field. To me, it's a message of optimism rather than pessimism, because the things that fit clinical realities first are going to last. They just have to be systematized. They have to be sort of filtered out and grown. But things that are built in the laboratory are sort of in the sanctified air of high IQs, have to be dropped down and then tested. And what we know is that has not gone very well for the practicing clinician, right? So clinicians generally have been very slow, if not unwilling, to adopt those kinds of theories. The ones that they've been more likely to adopt are the ones that resonate to everyday clinical realities. And that's always been my shtick.
No doubt.
I had many opportunities early in my career to be an academician, and frankly, I thought that academics at that point in time was kind of bullshit.
Yeah.
There was a lot of people pontificating about stuff who didn't even have licenses to practice, and they weren't, in my mind, that wasn't the way I wanted to go. So I by conscious choice, walked away. My good friend Neil Jacobson used to take me out to the dinner every year and give me the Wasted Academic Potential of the Year award. It was a free dinner.
I love it.
He never could get over the fact that I walked away.
Yeah.
Yeah.
Which again, isn't that is such an interesting, still probably, I don't know, a reality of our field, where clinical work oftentimes does seem, I don't know if this is good to say or not, but we'll say it almost seems like less than what like academia or whatnot might be. And I appreciate you saying that. And then also that idea of having these philosophies that embrace trial and error. I mean, we were talking about this this morning when you were shadowing me about, you might get to a spot where it's like, I know what's going on, I don't really know what to do, we're going to throw some things out, might work, might not work, and that error still is going to tell you what not to do the next time.
Yeah.
Yeah.
The therapist and the client are kind of facing the same problem in different ways. I mean, the client is not varying his or her behavior in a way that produces more effective responses, right? And so we're trying to get people to vary their behavior. That's the whole goal of therapy. It isn't to, satisfy navel contemplation, angst. It's to get people to try something different. And therapists have to do the same thing. You have to vary your approach and be willing to sort of live with the consequence. And if you get a consequence you don't like, you don't do that again.
Yeah.
Right?
Yeah.
Or don't do that again with that kind of patient, right? And over time, what you have developed is you have flexibility. So you're varying your behavior and you're helping the client vary his or her behavior. If you just thought about doing this work as your job is to get somebody to vary their behavior, you don't have to spend very long with people to get them to vary their behavior. It's more about what is the discussion we need to have about which behavior, right? It isn't measuring dissatisfaction or emotional distress. It's about assuming that the root cause of this is behavioral inflexibility, right? So people doing the same old, even though they're getting the same old consequence, and somehow being locked in that spiral. And so anything and everything is on the table in terms of getting people to move out of that spiral. That doesn't have to be something big. It just has to be something different, something that the client would look at it and say, that's a different way of responding for me, right? That may not be eventually the thing that they end up doing. It may not work as well as it needs to. That isn't the question. The question is, are you able to pay attention to consequences and then vary your behavior accordingly so that you're experimenting and moving around and looking for different ways to adapt to the situation you're in. All of our evolutionary systems are designed to help us do that, except one, and that is human thought. So if we didn't have a cognitive self, this discussion wouldn't be happening, of course, because we wouldn't be able to talk, but we would be doing all this automatically because we would be listening to emotional consequence. The emotions would motivate our behavior to explore and avoid things that are aversive to us and to seek things that are appetitive or, that create reinforcement. And the thing that gets in the way of that is the human brain, the more evolved part. So that's the part that gets in the way.
Let me ask you this, because the way you were saying it almost goes back to the conversation we were just having over after lunch, was training medical providers. And the approach that you just described about just being able to prompt some variation of behavior is something that PCP can do.
Yeah.
There's no question. So more of a specific question about this, is there, for people, behavioral scientists, for people working in family medicine residency that you did for a decent amount of time, what advice would you give those behavioral health faculty on what to be working with residents, future physicians to be able to do?
I think the reality with medical practice is people can't get into complexity because there's too many variables that have to be sorted out simultaneously. And I'm not sure complexity is a good thing anyway. I think that could be mental masturbation on our part with the client participating. So our minds are very busy engaging in verbal behavior and verbal analysis and storytelling and feeling really good about ourselves, or the client's feeling really bad about the story they're telling. But I'm not so sure at the end of the day that it doesn't come down to, if you don't vary your behavior, it doesn't matter what we talk about. Right? And actually nothing you're saying here is going to prevent you from varying your behavior if you decide to vary it. Right? And so for physicians, I mean, I used to say, and still do, it's all about approach and avoidance. So understanding what the person is drawn to in their life during a review of systems, interjecting things about what their passions are, what their enjoyments are, how they practice leisure, the meaning of relationships, just simple things that physicians want to know. They're going to want to know that about their patients. But this is putting that in a kind of a different context. This isn't just filling out a history in physical form. This is arming me with the things that this person is avoiding and the things that they're approaching, right? And if I had very, very limited time, which, most of the time is the case, I would be going in the direction of things that you're approaching. Why would that be better? Because when you try to get people to stop taking on aversive control, which is avoidance, aversion creates very narrow bands of behavior that are very, very rigid. They don't, what we call generalize. So they don't spread out beyond where the punisher is, right? The approach behaviors, on the other hand, when you practice those, they have a wide spectrum spread. So people like the feeling of approach-oriented behavior, what we might call value-oriented behavior, doing what matters to you, doing more of something that's giving you a sense of personal meaning, personal satisfaction. It's much easier to get people to move in that direction because the feelings widen. And I usually just tell people it's really hard to get people to stop doing things.
Yeah.
Which is what you have to do when you try to tackle avoidance, right? You have to say, you don't have to say this, but in effect, it's don't do this, right? The don't do this is don't avoid, don't practice aversive control on yourself. Instead, approach, right? So what we're doing is we're just cutting the link. I mean, a therapist can talk about avoidance,
Right.
but avoidance is a much more complex issue because people get their stories involved with avoidance. There's rationales, there's training, there's rules that they've learned, experiences they've had with their family of origins, things that they've been carrying around for years. And those things all push you in the direction of aversive control. And so that angle is a hard one to contain, right? I think if you gave me 30 minutes with somebody, I could go there. I could go to both places, easy. But in 5 minutes or 7 minutes of counseling, giving your patient's medical direction or advice, I just think you're better to cut the link and just to take the positive part and see if we can do more of that. Or this is something you used to do, you told me that this was a great source of interest to you, and it kind of stopped. Is there any possibility you could start it again?
Yeah.
And remember, this is only getting somebody to vary their behavior because they're sitting in a context in which whatever behaviors are happening. And so whatever consequential fields there are established, right? And so all I'm trying to do is what's the easiest way to get somebody to do something different? We'll get them to approach something, right? That they haven't been approaching, right? The real mechanism of change is the behavioral variability. You've changed the relationship between your organism and the surrounding field because you're doing something you weren't doing before, right? So I think it's a very simple, doable formula that doesn't seem Pollyannish to me, especially if you think about the things that really matter to people, if that's part of the assessment. Spending more time with your spouse because you've both been really busy at work and you're kind of, feeling a little more alienated. That isn't some kind of superficial thing. But it is behavioral variability. We're locked in a pattern of doing the same old thing. We both come home from work, blah, blah, blah. The outcomes are starting to become obvious. Nobody is satisfied. The only way we're going to get out of that is to unlock this rigid pattern and engage in something new. So,
and the thing that I love about it, on top of just the practicality of it, it's something I think if you would talk to a physician or a PCP about that it would be understandable, it would be digestible. The other thing that I love about it, two things. One, inherent in that is to get to know the patient, to get to know what is important to them, get to know the values. And we talked like last night about curiosity and what that does, is what curiosity produces. And the second thing about the relational frame that it starts to build between the patient and the provider, that the patient sees the provider as someone that, hey, they know me, they know what's important to me, they're moving me towards something that's approachable. I don't know, that's cool.
I think I would also, encourage teaching doctors to be curious. They're plenty curious about the meaning of physical symptoms, even though there's 5,000 or more medical conditions for which there's no known etiology. Right? If you could just be that curious about what floats this person's boat, what their passions are, what the important relationships in their life are like, the things that they are doing that give them a sense of sustenance. There's all this talk about how you build relationships. You build relationships by being curious about the person across from you. Because when you ask questions and you appear interested and you're asking about important stuff, you don't have to say, I care about you. It's implicit in the whole discussion.
It's there.
Right? So you're freed up from having to do all that verbal maneuvering, right? Because it's all implicit in the fact that I'm asking these questions means I care about you and I'm interested. And I think that also motivates people to follow any kind of suggestion or an agreed upon plan to try something different. Because they believe you believe in them.
Damn right.
Yeah.
Damn right.
That's the way it works.
It makes sense now for that to even be the natural behavior that almost like grows from that. Yeah. And it was interesting, another thing we were talking about this morning, of that, just what that curiosity does and how much that behavior in and of itself becomes an intervention of what we're trying to do. That's cool. I know Bridget's excited about this because I can see her off screen get really, really excited. Was there any questions that either of you had?
I guess that's just, I wonder if Kirk has a more eloquent way. That's how, like, when you really understand the contextual interview, like, that's what it is like you're not waiting to get something done. I mean, inherent in it is you're asking about their love, their work, and their play. Like, folks will look at the love, work, play as this like intake that we gotta we gotta do the intake, let's do the love, work, play, and then we'll get to the real stuff. And so what we're constantly saying is like, this is the real stuff. How do you get rapport? Well, I don't have rapport. How am I gonna ask them these questions? It's like, this gets you the rapport. So I don't know if you just want to maybe expand upon how asking about love, work, play, it is the thing. It's not do that and then we'll do the thing.
I heard a behavior analyst give a speech a couple of weeks ago about behavior change from a behavior analytic perspective. And he had something really interesting to say when somebody said, well, what about, are there some tips of the trade when I'm working with clients, And he says, keep assessing as long as you can. And what he was really saying is the very act of assessment is the intervention. The very act of identifying consequences and antecedents and things that come before you behave certain ways, having that discussion is so powerful that it almost sets the stage for self-generated change, right? So I don't mean assessing in the traditional clinical sense of, go back 17 generations in your search for mental disorders, But this kind of assessment, this functional analysis oriented, connecting the dots, I call it, for people, because people don't walk around seeing the dots and how they connect. They tend to focus on certain kinds of experiences, and they remain pretty oblivious to other contributing factors, right? And sort of in our culture, they're taught to generate mounds and mounds of verbal behavior about emotional experiences and the causes of them, but they don't actually understand the causes of their emotional experience. They have a verbally constructed view of what this is all about. Usually they'll have a historical bent, but it's only when you start talking about what are you doing now in your life and sort of how do these things sort of connect with your current behavior. And is the behavior you're currently engaging in giving you what you were seeking in life?
The truth criteria.
The truth criteria. Then, all of a sudden, emotional experiences start to come into a certain kind of clear focus that these are not destructive experiences, these are signals, right? That lurking out here, kind of unbeknownst to you, beyond the pale of your processing, are a series of unworkable things that are happening for you, right? And you're not trained to kind of think that way about how life works, right? I mean, we get terrible training in our society about how life works and how people, and there's almost virtually no credible explanation in current society for how people suffer. You either have a biological disorder or a mental illness. So people are basically flying blind. So I think the other thing that what this behavior analyst was saying is that you are waking people up to these important relationships between cause and effect, your behavior and the result of your behavior, spanning across sectors of your life, and then interacting with each other, right? And you're interacting also as the agent, right? So it isn't like you aren't you're not just on the receiving end of these things, you're on the delivering end of these things, right? Including the delivering end of your own experience, right? So even how you're responding to your own experience is going to affect your behavior outward, right? So little things like the contextual analysis, I think you could sort of say it's an interview, but really it's a functional analysis of the whole context that the person is operating in, with the assumption that probably 80% of this is unknown to the patient. Kirk, I don't understand why I just don't have no energy and I feel sad all the time. And then, lo and behold, my child is addicted to opioids and I'm tried everything in my power to get rid of it, but I didn't think that was related to sadness. Why would you be sad about that? I mean, believe it or not, that's what you hear.
Oh, for sure.
People are actually quite surprised that they have emotions and reactions to specific things.
Right.
And one of the big cultural myths that we battle with these poor models of suffering is that emotions just sort of appear.
Correct.
And are problematic. You kind of walk under the depression tree and the depression nut falls on you, and that these things are sort of stripped out of context.
Right.
And then the emotional experience itself is vilified, and it becomes the problem to be solved is the way you feel.
Right.
And that's
exactly.
why people come in for therapy.
Right.
The problem to be solved is the unworkable behavior behind the scenes that is resulting in the emotional experience you're having. But until you wake somebody up to that scene, they're just gonna keep saying, give me more drugs.
Yeah.
Or just help me feel better, I'll get on with my life when I'm not sad all the time. They have the cart and the horse reversed, right? So what this behavior analyst is saying is if you assess as long as you can, you're really trying to create a full screen picture of what this person is doing. And when they see what's on the screen, their emotional experience is going to be no accident to them.
Mm-hmm.
It's not going to be a mystery anymore. And it will also be solvable. Mystery illnesses like emotional problems can't be solved because they're mysteries, right? If this is no longer a mystery, hell yeah, the way you're describing this situation, anybody in their right mind would be sad and anxious. And the things, I'm guessing there's some other things that you've been experiencing. And matter in hell at times.
It would be weird if it wasn't there.
Yeah.
That would be more concerning.
Yeah, then I would be really worried about it.
I would be really worried about it. Yeah.
So let's not shoot the messenger.
Yeah.
Yeah.
Amen. That gets me
Let's
hyped.
listen to the messenger.
Gets me hyped. I'm assuming we're running long on it. How long?
Yeah, it's fine. 33 minutes.
33 minutes. Patty, anything that you're wanting Kirk to talk about?
No, I just love the emphasis on curiosity. And it's just so challenging to teach people to be curious when the context of the care they're delivering is in brief visits where they feel a lot of pressure. And so I would say that's the place we need to go with our attention. And I think what Kirk is saying is so true, that it's about in addition to staying in the assessment in a curious way, it's what you assess and how you direct that attention as you're really modeling curiosity in the context of delivering brief visits. It's tricky.
And maybe that's the first question we're going to lead off with you.
Okay.
With this
I'll do
next
that.
PCBH quarter. The last question I got to ask you.
Well, can I say one last thing about emotions?
No. Go ahead.
Emotions are not problems to be solved. Emotions signal problems that need to be solved. So our job, if it's behavioral variability, but with a certain kind of focus, right? Which is, this isn't designed to get rid of how you're feeling. This is designed to begin to make changes that need to be made, and your emotions are telling you need to make them. And they aren't gonna go away until they get made. That's predictive coding theory 101.
Well, and it goes back to what we were talking about before with the one patient that we saw, how beautiful that changes our relationship with those emotions, that we don't have to fear it. Like, this is something we should look curiously at. We should allow to be, it's telling us something versus something we need to hide and very rigidly try to get rid of. And it's here. Similar to what we told the one individual who, she said, I'm tired. It's like, yeah, when it shows up, let's
Lean into it.
Lean in. Let's keep going. Yeah.
Yeah.
It's cool.
Hug your tiredness.
Hug your tiredness. Yeah. So last two questions for you, very quickly. One, are we going to see you at CFHA in Boise?
No.
You son of a. What related to that?
We have 3 dogs, 2 of whom are less than.
What, you can't
2
bring
years
dogs to
old.
Boise? Come on.
No.
The
Dogs run everything.
The one thing I am curious about, it, this doesn't have to be an expansive one, what's next? Like, what are you going to do next, man? Like, obviously you're finishing up this book, you're getting this done. I mean, what's the next journey?
We'll see.
Yeah. Okay.
That's
I
good.
like it. I like it. Well, thank you all again, as always, for joining Kirk. Thank you for being here.
That was awesome.
Appreciate it. All right.
Thanks for having me.
Yeah. Take care.
That was